أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الرحمن علم القرآन خلق الإنسان علمه البयान। तो आज एक नए टॉपिक के साथ एक नई अहम बात के साथ रिमेंबर सक्सेस इज़ नॉट फाइनल, फेलियर इज़ नॉट फेटल, इज़ द करेज टू कंटिन्यू दैट काउंट्स। तो आप लोगों ने मेहनत करते रहना है। ज़िंदगी एक मुसलसल मेहनत का नाम है। आज जो मैं टॉपिक आप लोगों के साथ डिस्कस करने जा रहा हूँ, ये टॉपिक है एब्डोमिनल ट्यूबरकुलोसिस। तो सबसे पहले कुछ पॉइंट्स की इट्स अ ट्यूबरकुलोसिस ऑफ जीआई ट्रैक्ट, पेरिटोनियम, lymph nodes and or solid organs, and it comprises 5% of the TB. The commonly involved sites include peritoneum, intestine and or lymph nodes. It occurs via reactivation of the latent TB or ingestion of unpasteurized milk or undercooked meat. So something about the intestinal tuberculosis. It can present the two type of bowel lesions. It can present as ulcerative lesions, which is more common in malnourished children, and it involves a small intestine commonly. Whereas the ulcerohypertrophic type of TB occurs in the relatively well-nourished patients, and it involves the colon or ileocecal. The most common site is ileocecal because of stasis and abundance of lymphoid tissue in that place. Young adults, primarily women, are affected in Pakistan or Turkey. So, something about the hepatic tuberculosis, it presents in two forms. One is a miliary hepatic disease, which occurs in 80% of the cases of miliary TB, and TB reaches via the hepatic artery. Remember this difference. And then is isolated hepatic disease, in which case the TB reaches via the intestinal tract via portal vein or GIT lymphatics, and it is due to reactivation of the latent TB, and it's very rare. Pancreatic TB is very uncommon, and a differential diagnosis of pancreatic malignancy should be considered. The risk factors of TB are the chronic liver disease, HIV, diabetes mellitus, malnutrition, CAPD. Within the first year of the CAPD, this presents, and the most common DD is of bacterial peritonitis, and the corticosteroid. The patients taking corticosteroids are at risk of developing abdominal TB. So, how they present? They can present in a variety of ways to you in the OPD with the fever and fatigue, which is the most common, nausea, vomiting, weight loss. These are the common symptoms of a TB. But there can be pain abdomen, which is the most common symptom of abdominal TB, abdominal distension, diarrhea, which is chronic. There can be mass abdomen, intestinal colic, constipation, and bleeding per rectum can occur. Other here will be the history of TB in the family, whereas the other history like birth and these histories will be non-significant in this case. So general look will be the patient will be the sick looking. The vitals can be as per the temperature, hypotension, and respiratory rate will be increased. Whereas the specific signs relative to the abdominal TB, that the abdominal there will be lymphadenopathy, there will be jaundice in case if the liver is involved. Abdomen feel will be the dewy abdomen. Abdomen will be dewy on palpation. There will be hepatomegaly in case of hepatic TB. There will be splenomegaly. There will be ascites in case of peritoneal TB. There will be no signs of CLD. If there is no signs of CLD and these are the findings, then keep TB peritonitis on the top differentials. So something about the differential diagnosis. Crohn disease. It is very difficult to differentiate abdominal TB from the Crohn disease. However, on biopsy in Crohn disease, there are non-caseating granulomas. But if you don't know anything, it is not clear to you whether it is Crohn disease or TB. Give a therapeutic trial of ADT for 2 months. If no improvement, then consider Crohn disease. So CLD is a common then a malignancy like the pancreatic malignancy, ovarian malignancy. They can have hemorrhagic acidic fluid. Lymphoma can also. Then the diagnosis and investigations. Mostly this is a clinical diagnosis. However, some diagnostic investigations include the most common is ascitic therapeutic oblique diagnostic tab. The ascites fluid color will be the straw color. there will be increased leukocyte count, which will be 150 to 4,000, and there will be lymphocytes. Protein count will be greater than 3. Adenosine deaminase level is elevated 30 to 39 international units in the absence of CLD. So mycobacterium culture in the peritoneal fluid, ascitic fluid tap, is very important, but it has low sensitivity and the yield increased if around 1 liter of the peritoneal fluid is cultured. Then serum ascites to albumin gradient will be less than 1.1 gram per deciliter in the absence of cirrhosis. Peritoneal biopsy, if you are not clear about the diagnosis, site of involvement depends upon which site to take in endoscopic in intestinal TB, whereas the liver biopsy in case of hepatic TB. The histopathology will show the caseating granulomas. X-ray abdomen will tell you air fluid levels in case of intestinal obstructions. Ultrasound abdomen is done for seeing the lymphadenopathy and mental thickening. CT with enterography protocol, it's a prefer for, and this tells us the mural thickening. Small bowel follow through or a Barian enema will tell us about the ulceration or stricture. So supportive treatment you can do CBC and ESR which show anemia, white blood cell common in 50 to 80%. ESR will be raised. LFTs, there will be mild elevation of ALT and disproportionate increase of alkaline phosphatase in case of hepatic TB, HIV testing. Then you will do the other supportive testing or depends. The treatment is a specific, you have to give the ATT. In this case, the fever resolves in a week and the improvement within few weeks, normal 2 to 4 weeks. Consultation, you need the surgical consultation depending upon the complications. Thank you very much for your listening and do give me your feedback. May Allah be our helper, protector and guide. Allah Hafiz.